means metastasis in multiple lymph nodes in the true pelvis, and N3 means metastasis in common iliac lymph node. M means distant metastasis. MX means distant metastasis cannot be assessed, and M0 means no evidence of distant metastasis. M1 means there is evidence of distant metastasis. The clinical manifestations for blood cancer is when we ask the patient history is very important. All important information with possible connection to blood cancer should be recorded, including risk factors and a history of suspected symptoms such as tobacco smoking. And the typical and the most common symptoms for blood cancer is painless gross hematuria, and it can be found intermittently. Patients with irritative lower urinary tract symptoms refractory to symptomatic treatment, carcinoma in situ might be suspected. For most patients, there is no pertinent physical signs. And the laboratory tests for blood cancer, urine test, in urine analysis we can find hematuria. And the urinary cytology is also very important. It has high sensitivity in high-grade tumors, but low sensitivity in low-grade tumors. And for blood cancer, we can also use tumor markers, but it's not so specific. For example, BTA, NMP22, and telomerase. How to diagnose blood cancer? We can use also, it depends, also very important on the imaging techniques. Ultrasonography is used as the initial tool to assess the urinary tract. Ultrasonography permits visualization of the intraluminal masses in the bladder. Here, the picture here shows blood tumor in ultrasound. And IVU is used to detect filling defects in the calyces, renal pelvis, and ureters, and hydronephrosis, which can indicate the presence of the urethral tumor. And the picture here shows the filling defects in IVU, suggests blood tumor. And CT scan is used as an alternative to conventional IVU, especially in muscle-invasive blood cancer. CTU, that means CT urography, gives more information than IVU, including status of lymph nodes and neighboring organs. Here, the picture here shows the blood tumor in CT scan. And the diagnosis of blood cancer ultimately depends on cystoscopic examination and histological evaluation of the resected tissue. Here, look at here, the blood tumor here, in different shapes. And careful inspections of the whole urothelial lining in the bladder should be performed to prevent missing the tumor. And fluorescent cystoscopy can improve sensitivity, especially for hidden tumor. Look at here, the picture on the left and on the right. The right picture shows white light cystoscopy reveals normal appearing mucosa. But if you change to blue light cystoscopy, it can reveal the accumulation of hexaminolevulinate in an area proven subsequently to contain a small focus of carcinoma in situ. And also, it's very important to differentiate breast cancer from other disease. Upper urinary tract urothelial cell carcinoma is the first disease we should consider when we diagnose breast cancer. Patients with cancer of the upper urinary tract have a 30% to 40% chance of developing cancer of the bladder at some point in their lives. On the other hand, patients with breast cancer have a 2 to 3% chance of developing a cancer of the upper urinary tract. So after we have diagnosed breast cancer, how can we treat the patient? So therapeutically, breast cancer can be classified as non-muscle invasive breast cancer and muscle invasive breast cancer. And non-muscle invasive breast cancer is traditionally known as superficial breast cancer. Malignant urothelial carcinomas that have not invaded the level of muscle, that is carcinoma in situ, TA and T1. And a muscle invasive breast cancer is malignant urothelial carcinomas have invaded over the level of muscle. That means equal or more than T2. So for non-muscle invasive breast cancer, that they are TA, T1, and TIS. The standard treatment is transurethral resection of the blood cancer, which is abbreviated as TURBT. And after TURBT, intravesical chemotherapy or immunotherapy should be given. And they will have a clear impact on tumor recurrence. And also, another very important thing after transurethral resection of the blood tumor is the regular cystoscopic surveillance. And for muscle invasive breast cancer, the standard treatment is radical cystectomy. And what is the indication for radical cystectomy? Traditionally, radical cystectomy was recommended for patients with muscle invasive breast cancer T2 to T4A, N0 to NX, but M0. That means no evidence of distant metastasis. And other indications include high risk and recurrent non-muscle invasive breast tumors, BCG resistant carcinoma in situ, T1, G3, as well as extensive papillary disease that cannot be controlled with TUR and intravesical therapy alone. And how can we perform radical cystectomy? That means the surgical extent in male and female patients is different. In a male patient, we should remove the prostate. We should remove the prostate, seminal vesicle, and bladder. And in a female patient, the anterior exenteration requires removal of the uterus, fallopian tubes, ovaries, bladder, urethra, and a segment of the anterior vaginal wall. But with radical cystectomy, we should perform at the same time the bilateral pelvic lymphadenectomy. Bilateral pelvic lymphadenectomy. And after radical nephrectomy, we should perform urinary diversion. It includes different types of urinary diversions. For example, urethral cutaneostomy, brick operation, orthotopic new bladder. And after radical cystectomy, for some patients, we should also give the patient adjuvant chemotherapy. So adjuvant chemotherapy after radical cystectomy is used for patients with PT3 and T4 and or lymph node positive disease without clinically detectable metastasis. So that's all for blood cancer. And finally, we will discuss prostate cancer. Prostate cancer is a form of cancer that develops in the prostate, a gland in the male reproductive system. Most prostate cancers are slow growing. However, there are cases of aggressive prostate cancers. The cancer cells may metastasize from the prostate to other parts of the body, particularly the bones and lymph nodes. Prostate cancer is the most common cancer diagnosed and is the second leading cause of cancer death in American men. The incidence of prostate cancer is continuously increasing each year in China. The incidence increases with advancing age. So, prostate cancer nowadays is a growing health problem. The etiology of prostate cancer is not fully elucidated, but there are some factors related to prostate cancer. They are age, inflammation, infection, and genetic susceptibility, race, positive family history, high dietary fat intake, hormonal factors. Pathologically, over 95% of the cancers of the prostate are adenocarcinomas. Of the other 5%, 90% are transitional cell carcinomas. And the remaining cancers are neuroendocrine, the so-called small cell carcinomas or sarcomas. And prostatic intraepithelial neoplasia, which is abbreviated as PIN, and a typical small acid proliferation, which is abbreviated as ASAP, are thought to be precursor lesions of the prostate cancer. Approximately 60 to 70% of prostate cancer patients originate in the peripheral zone, and 10 to 20% originate in the transitional zone. And finally, 5 to 10% in the central zone. So pathologically, how to grade the prostate cancer? The Gleason score, the Gleason systems, is widely used for its best clinical correlation. So the Gleason scale from 1 to 5. And the Gleason score or Gleason sum is obtained by adding the primary and secondary grades together. Gleason sum of 2 to 4 means well-differentiated tumors. Gleason sum 5 to 6 means moderately differentiated tumors. Gleason sum of 8 to 10 means poorly differentiated tumors. And Gleason sum of 7 is grouped with the moderately differentiated tumors or polydifferentiated tumors. And also it's very important to stage the prostate cancer. It's very important for us to make a decision making in the treatment of prostate cancer. And we quite often use also the international TNM staging systems to stage prostate cancer. And the T here also means primary tumor. TX means primary tumor cannot be assessed. And T0 means no evidence of primary tumor. And T1 means clinically inapparent tumor, not palpable or visible by imaging. T1A means tumor incidental histological finding in 5% or less of tissue resected. T1B means tumor incidental histological finding in more than 5% of tissue resected. And T1C means tumor identified by needle biopsy, for example, because of elevated prostate-specific antigen level. And T2 means tumor confined with the prostate. T2A means tumor invades 1/2 of one lobe or less. T2B means tumor invades more than half of one lobe but not both lobes. T2C means tumor involves both lobes. T3 means tumor extends through the prostatic capsule. T3A means extracapsular extension, unilateral or bilateral, including microscopic blood neck involvement. T3B means tumor invades seminal vesicles, unilateral or bilateral. T4 means tumor is fixed or invades adjacent structures other than seminal vesicles, external sphincter, rectum, levator muscles, and or pelvic wall. And N means regional lymph nodes, and X means regional lymph nodes cannot be assessed, and N0 means no regional lymph node metastasis, and 1 means regional lymph node metastasis. M means the distance metastasis. MX means no evidence of distant metastasis. M0 means no distant metastasis. M1 means distant metastasis. M1A means non-regional lymph node. M1B means the metastasis to bones, and M1C means to other sites beside the bones. And the clinical manifestations of prostate cancer at early stage, it is asymptomatic. But for locally advanced or metastatic prostate cancer, obstructive or irritative voiding complaints, bone pain, paresthesias, and weakness of lower extremities are quite often. How to diagnose prostate cancer, especially at early stage? Very important is the first examination is digital rectal examination. So this is the rectum, and this is the prostate, and this is the bladder, and it is very important for us to find prostate cancer at early stage. And the second important early diagnosis tool is a blood test to measure prostate-specific antigen, which is abbreviated as PSA, in the serum. Usually, the normal range is less than 4 nanogram per milliliter. If the patient, his PSA ranges from 4 to 10 nanogram per milliliter, we call this gray zone. And if the patient serum PSA level is more than 10 nanogram per milliliter, it is highly suspected of prostate cancer. And the third tool to early diagnose prostate cancer is the imaging study. First one is transrectal ultrasonography. We can find hypoechoic lesion. Look at the picture here. Hypoechoic peripheral zone lesion in the right mid-gland. And the second imaging technique to diagnose prostate cancer early is MRI. It is the most commonly used technique to image the prostate gland, especially when prostate cancer is suspected. Look at the picture here. This is a 65-year-old man with stage T3A, Gleason score 4+3 prostate cancer at the left peripheral zone. And bone scan will be used when prostate cancer metastasis. So look at the picture here. It shows multiple bone metastasis in bone scan. And most important diagnostic tool is prostate biopsy. It is the gold standard. So this is bladder, this is the prostate, and this is rectum. Prostate biopsy should be considered in men with an elevated serum PSA, a DRE, or a combination of the two. So, how to differentiate the prostate cancer? Other factors that elevate serum PSA include benign prostatic hyperplasia, urethral instrumentation, infection, prostatic infection, or vigorous prostate massager. Induration of the prostate is also associated with chronic granulomatous prostatitis, previous TURP, that means transurethral resection of the prostate to treat benign prostatic hyperplasia, or needle biopsy, or prostatic calculi. So after we have diagnosed prostate cancer, we should differentiate the prostate cancer patient as localized or locally advanced or metastatic. For localized prostate cancer, there are some choices. One is watchful waiting, or the so-called active surveillance. It is indicated to older patients with small, well-differentiated cancer. But the standard treatment for localized prostate cancer is radical prostatectomy. It can be used, so this is the bladder, this is the prostate. And radical prostatectomy means we remove the whole prostate with seminal vesicles. They are indicated in patients with a life expectancy more than 10 years. And we can also choose radiation therapies to treat localized prostate cancer. And radiation therapies for prostate cancer can be also classified as external beam therapy and brachytherapy. But for locally advanced or metastatic disease, the patient should be given endocrine therapy. That is androgen blockade, because prostate cancer is dependent on androgen levels in the serum. So we can block the androgen through orchiectomy, through anti-androgen agent, through LHRH agonist. And for locally advanced or metastatic disease, we can also use other treatments. The picture on the left here shows the external beam therapy. It is 3-dimension conformal radiation therapy to treat localized prostate cancer. And the picture on the right shows also the brachytherapy. We use the radioactive seed implants to treat also localized prostate cancer. So if the patient with bone metastasis, we can also administer patient the Zoladex, etc. So for prostate cancer, that's all. For prostate cancer, the etiology, the epidemiology, the clinical manifestations, diagnosis, and treatment. So that's all for today. Thank you.